So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
Alrighty, welcome guys to the first ever Pharm So Hard, a live episode. Again, of course guys, it's me, Jim Priano, aka PharmD in the ED, and I'm super excited to have the person who got me into ED, who really got me moving forward. I have Jim Priano, the man, the legend himself, the pimp master, here today to talk to us about TPA versus the new boy on the block, Tenecteplase. We can call this one Talking Heads, right?
Oh boy, you give me too much credit. Thanks for having me, man.
So super excited to go about this, and it's going to be a little different. Again, most people do presentations in this setting, and for me, I want to just be able to go through some information, ask some questions, drink a few beers, just have a good time, and just have everyone together and just go through a few things. So I really just wanted to see, let me get this thing all set up where we need it to. So talk about a few things, but before we get too deep into all of this, let's kind of just bring things back and just talk about just the heart and the brain and continue behind that. So to talk, like, why should we even care about these things?
So, I mean, when we think of, in the gross sense, an ischemic stroke is really just like a STEMI of sorts of the brain, right? And STEMI management has really outpaced stroke management. They're about 20 years ahead or so. And so if we just think that a STEMI is going to have a blockage for some reason of a coronary artery, causing some cardiac ischemia and downstream effects. Well, it's not too dissimilar from what's going on in the brain for ischemic strokes. You got a clot, whether it's thrombotic, embolic, that doesn't really matter. You got a clot forming tissue ischemia, and we got to open up the artery, and so we could restore perfusion to the brain.
So I think the way I always think of this is that I'm just a real simple guy. Again, you're the smart one. I'm just the one that's here. I think of all of this as like my toilet's clogged up.
We got to open it.
Or I have like my shower is messed up because someone is washing their hair with all these nice products and the shower's clogged up, and I got to get some Drano and just to bust that clot wide open.
Because if you don't bust that clot, you're going to have some bad downstream events. Right?
And a plumber cost is going to be much higher than the $5 for the Drano. So
exactly.
I always think of this as like I want to just be able to create that flow to where nothing's backing up and there's nothing happening in the downstream. So
but again, but using that analogy, you could open up that drain using a lot of different methods, right? But some are going to cause some havoc downstream and might involve plumbing explosions on the other side. And so we're trying to do it in the most logical and safe process, whether it's plumbing or doing the plumbing in the brain.
So again, I think that's the big thing. But I think a lot of this, you talked about how we're really behind. And I think I gave a presentation during residency with you when I first heard about thrombectomy. And I was like, our brains are going to follow our heart for once. And every time I think like, hey, this is in 2017, and we really haven't had the luxury of getting together and say, hey, we've been doing this since the 90s in the heart. But give us like a timeline, like what was going on as far as like from acute myocardial infarction standpoint, and like where have we come?
Yes. So the heart is we can say it's a simpler organ than the brain, and so therefore we're able to maybe advance our knowledge of it a little faster. But I mean, going back to the Middle Ages, they used to just treat STEMIs or people having chest pain with just pure bed rest. And this progressed for hundreds of years, and it wasn't even until like the 50s where did they develop these coronary or cardiac critical care units, and they actually dedicated the entire unit for treating the heart. And this is where they started first using streptokinase. Streptokinase to derive literally from bacteria to try to lyse open some of these vessels. And then, but they were finding that there's a little bit of bleeding and some allergic reactions going on with the streptokinase, and so they thought there has to be a better option. And so back in 1990 was a trial comparing streptokinase to Alteplase in STEMIs, and they find out that Alteplase works just as well, but it has less bleeding. And so therefore, let's try to use this new kid on the block, use this Alteplase drug. And so they try to change up the infusion strategies of Alteplase to make it a little bit more preferred, as it's a little short acting, and but it still wasn't perfect. Yeah. And so they were trying other methods. Be like, hey, is there a better drug? And so they said, well, what if we change up some things with the lytic and we try this new one called Tenecteplase, and we're finding that, hey, it works just as well as Alteplase, but even less bleeding. But what really changed was in the 80s when we started using or 80s and 90s rather, we started using PCI. We started treating these patients as surgical emergencies, and so the Gusto trials where they compared PCI or the cath lab to this new accelerated Alteplase, and it's a new paradigm for how we treat STEMIs, right? You have a STEMI coming in the ED, you don't even think about, oh, should we get our TPA ready? Yeah. It's which cath lab are they going to right now, right? And so it's we're getting that way with stroke management, but we're about 20-ish years behind.
Yeah, it's something that I think is interesting, and it's like we have all these tools available to us, and our technology is much better. And I'm thinking like, man, like it's for one, I asked myself, is PCI going to get better? Is it something we're just not talking about? And are we going to be able to get deeper and deeper in the brain?
Yep.
And basically suck out these clots.
Oh, I can't wait
to get better. So we'll wait a little later from that. But again, let's talk about some of the historic stroke management, because I did some stuff on this, and I thought it was funny, like some of the things physicians were saying back in like the 16 and 1800s, like don't even try.
Yeah.
Like you make yourself look horrible. Don't even try.
Oh,
let's take a history.
It's amazing. So something I ask my residents is something as very simple as, why do they call it a stroke? Yeah. Right? And they're like, oh, I don't know. And if you actually look up the etymology of the word stroke, it's coming from the stroke of God's hand, that you were stricken. And so that's why the person is having the prototypical stroke findings. Yeah. And so they used to just treat this, they called it apoplexy. You were suffering from the stroke of God. Yeah. And so we stuck with this for hundreds of years. And so I was talking to some more senior physicians in the ED, maybe a few weeks ago, and he said that when he did his residency back in the 1980s, he goes, we weren't even in a rush to get a CAT scan of people who were having a stroke, because if you had an ischemic or a hemorrhagic, it didn't matter then. How about that?
Like, to now, it's like, you better get there. Don't even get off the stretcher.
You got 10 minutes.
Like,
go.
Get to there now. Do not cut 200. Go straight to the cath lab. Versus then it's like, oh, it doesn't matter.
Yep.
And I think sometimes we think about these time periods being such a small period of time, but we've been looking at this condition for hundreds of years, and then we say, oh well, in the 90s we start doing something a little different.
Now we could actually treat it.
And we changed the entire management and the systems, and how we even think about stroke is completely different.
Absolutely.
Over the last 20 years. So great for modern medicine, but I think it's pretty intriguing when we start looking at the timeline of like, this is not even something you can treat. Yep. It doesn't even matter in the 80s, where all of us should know someone that was an adult in the 80s.
So really just in the past 30 years is we could provide some treatment for these people with ischemic stroke. And so back in 92 was the first time they thought of using Alteplase. So again, it's already been being used for STEMIs, but now they say, hey, it's kind of like a STEMI of the brain. Let's try it. Let's give a dose ranging study, and they ended up at this 0.85 or round to a 0.9 mg per kg, because any dose higher ended up bleeding a little bit too much. But then we had that pivotal trial, the NINS part 1s and 2, right? Yeah, that's a big one. Back in 95, and so Alteplase versus standard of care, and
it's definitely true. We can probably.
We're not doing a journal club on that one.
We don't want to go deep dive. Anyone who knows me, if you guys are watching, if you know me, if you want to get me fired up, let's talk about study designs and how I call it statistical gymnastics. We just made things happen, and it just rolled that way.
Long story short, it's FDA approved.
Yep, and there's a lot of belief and money going towards making sure that
Yep.
happens. So,
Well, and so with that being said, with the continued search to try to make things better, right? Because it was not without its flaws.
Yeah.
I mean, that gives us hours of discussion for one trial. And so we wanted to see, well, could other lytics work?
Yeah.
And so they tried the streptokinase, and it didn't work.
Yeah.
And now we're trying Tenecteplase, and we're saying maybe it works. But then again, similar to PCI in STEMI, well, actually, it might be a surgical emergency. 2015, you have 5 huge trials that says, let's take that clot out.
Yep.
And these patients are doing night and day better within an hour or two.
yeah. So it's definitely intriguing, but I won't belabor that. That's that whole thing by itself. We talked about Alteplase, but just very briefly, like for people who just seeing this and we may chop this up, how does Alteplase work? What's the thing with Alteplase?
Alteplase, it just goes and activates plasminogen to cleave plasmin to start munching up a clot.
Yeah.
And so they call it a powerful clot buster, and it just is an exogenous. So we are giving additional drug that's already in us. We have circulating tissue plasminogen activator in us already, and this is just a mega booster dose to go and dissolve any clot anywhere in your body.
I try to explain it as like, okay, we have a fish in a net, right? And we have a fish net. The fishes are out there. And you have this big thing in there, and that's your clot. And I think of it, you have these huge scissors that are coming, and it's cutting that net open, and that's what TPA does. That's the big thing. It just goes through and it just cuts up and lets all these things free, so you can go through it. But it happens everywhere in the body.
Everywhere in the body. It's not really specific, and it does cause some depletion of certain protective enzymes, and so maybe you have a little bit of bleeding. But maybe if there's a better way.
Perfect. So again, that's Alteplase, and of course we have the bolus and infusion and things like that, and that's great. Let's and we kind of went back. And what are some of like the things that are the downside of Alteplase? Why should we even look for something different?
Yes, so it's maybe not perfect. So it has like a half-life in like the minutes range, about like 5 or 6 minutes. And with this being said, it does require a loading dose. So we give that 10% over a minute, and then the remainder over an hour. So a continuous infusion for an hour. It does have that bleeding risk. So some of the studies are saying it's around 6-ish to 7% of symptomatic ICH, which is a concern. But now we're finding that it might not work in certain populations. And so if you have like a large clot burden or like a large vessel occlusion, it might not actually get around to the entire thrombus and to dissolve it all. And it may be in centers that don't have maybe dedicated ED pharmacists, and you have a nurse-driven stroke protocol, it might be complicated to do a weight-based dosing with the bolus and infusion as well, which could lead to errors.
Yeah. That's one thing, and I think that's what made me think about this. The new kid on the block. It shouldn't necessarily be too new.
Not too new.
But it's just a newer kid on the block for us for stroke.
For the brain, because again, it's been being used for STEMIs for 20, 30 years.
So TNAK, so Tenecteplase, like what's the gist of that? What's the unique thing about that?
So the gist for TNKase is literally 3 substitutions of the Alteplase molecule. They substitute at the T site, the N site, and the K site, and synergistically, this gives it a longer half-life, more fibrin selective, and it prevents degradation. And so we're able to give it as a 5-second bolus, and it lasts longer, so you don't need the continuous infusion, and it might be more fibrin specific, and so it's a little bit, in theory, has less bleeding.
Okay. So we'll tackle that later on. All right, perfect. So like when we take a step back and we look at some of the dosing and things of that nature, again, you mentioned that Tenecteplase is going to be in a bolus just over a couple seconds. Alteplase is going to be a bolus and an infusion. What about dosing? What do we see as far as from Alteplase and then for Tenecteplase?
Yep. So the classic dosing, at least in North America, is going to be the 0.9 mg per kg with the 10% bolus, followed by the 90% infusion over an hour. For Tenecteplase, the dose that is most currently accepted is just this one-time 0.25 mg per kg, cap at 25 milligrams, IV push once.
Yeah, and I believe that just that part right there is probably controversial as well. I've had many people reach out and say, hey, my doc wants to use Tenecteplase and he wants to use this dose.
Yep.
And that dose may or may not be what's the most commonly, utilized, but that's a different thing. But it's just every part of this conversation can be its own sidebar, and we can go into that. But I think just looking at those two is saying, okay, we have one that's a little bit more fibrinogen selective. We have one that's that has a little bit more fibrinogen degradation. That's something that's unique. And then one of the things that we look at, and I think our providers think we look at a lot more, is the cost. Yeah. I know we have these different different ways we can cost structure. Generally, we would say, is one more expensive? Is one is it similar? What's the deal with that?
In general, again, it depends on your purchasing power, but Tenecteplase is about 25% cheaper than Alteplase.
So I think a lot of times when we hear our colleagues say, "Oh, you guys just want to use this drug because it's cheaper," and we can talk about studies and stuff later on. But I think it's unique to say the newer kid on the block is actually a little cheaper.
Yeah.
So again, newer. I know this has been for quite a while since I was probably in elementary school. But again, it's unique to say that this thing that we are suggesting, it has an argument for it. It may be a little easier to get.
Absolutely.
It's a little cheaper.
Might be safer.
So we can dive a little deep into that. I don't want to go too much into some of the background, but if you wanted to talk about some of the efficacy and what are we looking at?
Yes. So big picture. Back in the 90s, when Alteplase was being studied to standard of care, like in the NINS trials, we were really just trying to do these various scales and see how well does Alteplase versus placebo work at improving the MRS or the NIHSS stroke assessment scales, but they're not necessarily perfect because it's the physical ramifications of the stroke. It's not necessarily the exact what's going on in the brain, right? And so, but for years, that's what we used. And so Alteplase got approved because it improves your odds of having a favorable outcome 3 months later in some of these stroke scales. But nowadays, we're actually able to visualize the stroke. Right, we didn't have this more advanced imaging technology, and so those 2015 trials that look at large vessel occlusions, they require you to actually look at the area of infarct or penumbra, and so we could use CT-guided imaging if you have IV contrast currently, and you can calculate what area of the brain is being suffocated and what can you save or can you not save, and it's only risk. And so now we can help rule in these patients, and then you take them up to the neuro IR suite, and you could actually say, hey, if we get reperfusion, we have a really good chance of favorable outcome. Right.
So that's the unique part about all of this, knowing that we have all of this component. And we mentioned very briefly in the past, what do we get with Alteplase? What are we getting? And for better or for worse, we know that potentially we get 30% improvement and modified rankings go. And this, again, as you mentioned, 90 days. I love it when my team say, "Oh my God, Jimmy,
it's working."
Just like that. You got 2 seconds of the bolus in, and the patient is rapidly improving. You saved this man's life. But most of the data, again, the only ones that I know, maybe I'm not smart enough to know some of these trials that haven't been published yet that says that you save people within minutes of giving TPA. But what Alteplase says is that 90 days, and then 10% reperfusion rate in these large vessel occlusions that you mentioned, and then the bleeding risk you mentioned as well. Again, symptomatic.
That's there. Yeah.
Not I just accidentally saw this on the CT for something else. This is the real deal.
Yep.
And I think it's unique for everyone out there. It's pay attention to what we even call symptomatic ICH.
That's another discussion there. Yeah. Oh yeah, that's petechial hemorrhages.
But again, we mentioned a lot about these large vessel occlusions and how to manage them. Can you kind of go a little deeper into that?
Yes. So the large vessel ones, we're thinking that this is going to be the middle cerebral, the internal carotid, or maybe a basilar artery. So these are the large vessels we can visualize on a contrast-enhanced CT. Yep. We could access with some of our thrombectomy or our stent retrievers in the neuro IR suite, and these can be managed a little bit differently because they could be a surgical emergency, like the MR Clean trial, Swift Prime, all those, compared to the medical therapies from the NINS trials. Now with the LVOs, the stroke guidelines, it still says continue to offer Alteplase to these patients with a level 1A recommendation because it is standard of care. And so Alteplase beat them to the punch by 30 years, and it is still in the guidelines, even though there are some studies that compared LVO management with just mechanical thrombectomy versus thrombectomy plus Alteplase, and they found very little difference, maybe just a bleeding difference. I wonder where that was from. But then, and there's also possibly a theoretical element of concern, right? If we're offering these LVO patients Alteplase, for instance, a lytic, and then we're going up into their brain with a stent retriever and actually manually manipulating the clot, what if that lytic changes the composition, have some like thrombus fragment, and then goes more distally, and now we cannot grab that clot? Like, did we just make things worse? And that's been shown to happen about almost a quarter of the time, where there is fragmentation or distal movement of the clot.
That's big, because you think about all of what we're doing, it's like, wait a second, 1 in 4 patients?
Yeah. Because down in the ED, we don't necessarily have that downstream view, right? And so we treat the patients right here, right now. Next.
You go upstairs, and that's that. So that's definitely intriguing. And there's some data looking at Tenecteplase early on, again, in the later 2000s that we want to go into. Can we just go through a few of these, like Tenecteplase studies, and just say, what are we even looking at? Because like most of the time, people hear these conversations like, well, I'm always going to use Alteplase. No matter what. The discussion is Alteplase or thrombectomy. It's not Alteplase or Tenecteplase. So let's go through a few of those.
So some of the big picture stuff is that we're trying to find a better way, right? And so Alteplase is not without its drawbacks, right? We say, hey, it's not really working for these LVOs. Is there a better way to do things? And so it was like, I think in 2005 they started looking into it, and in 2010 they tried a phase 2 trial for a dose ranging study for Tenecteplase in strokes. And so they started off with 0.1, 0.25, 0.4, and they compared it to Alteplase, really small sample size, and all they found was 0.1, 0.25. It works similarly to Alteplase at these arbitrary endpoints, and 0.4 might cause a little bit of bleeding, and so let's not do 0.4. And so they're like, hey, maybe this has some hope. Let's study more for Tenecteplase. So then we got into a little bigger trial. So the ATTEST trial is like 100-ish patients, where they compared 0.25 mg per kg of Tenecteplase versus standard dose Alteplase, and their primary outcome is the surrogate, again, of the CT perfusion-guided reperfusion at 24-ish hours. And they found out that it works just as well. Alteplase versus Tenecteplase gets the same amount of reperfusion in these in the infarcts that they had in the ATTEST trial, and they had maybe a little less bleeding, but it was not clinically significant yet.
So that's unique, because again, we take a step back and just the baseline stuff. If it's just the same, we have a drug that's probably easier to give and a little cheaper. And I think people don't. We should really emphasize the fact that giving the process of giving TPA, I think it's not a problem for me, but the system around administering TPA 24 hours a day is challenging. So if we just take a step back here in 2015 and say, hey, if it just works well, maybe a little less bleeding, I can't have anything strong, this is where things get interesting now. And I think this is when in 2015, all the thrombectomy trials, all these things are happening, Mr. Clean is going on, all these great things are happening. It's like, wait a second, this is where I think things really got interesting, and we should start looking at some more stuff. So let's go to...
So maybe we should get a bigger study, huh?
We should go a little bit more.
So the NOR test comes out, 1,100 patients, right? They kind of missed the ball where they enrolled mainly minor strokes. It was not their intentional purpose, but they mainly got an NIH's like 0 to 7 and fewer of the moderate to severe strokes. Spoiler alert, just came out recently. And so they actually did an intervention of 0.4 mg per kg of Tenecteplase versus standard dose Alteplase. And they didn't really find many differences between like the bleeding rates, the improvement at 24 hours. And so then they wanted to look at, well, is there actually some improvement in the more severe strokes? They did a subgroup analysis of their moderate to severe strokes. And again, no real difference in the moderate ones. These are NIHs of like 6 to 14, and then in our severe strokes, there might be more bleeding and additional rates of mortality. But again, it was not powered and super small sample size in these severe strokes, which they addressed recently.
So again, like that component of having these smaller, these milder strokes was a big deal. So I think everyone looks at that and say, well, great, that 0.4 mg per kg again wasn't necessarily the most commonly used.
But again, it didn't. The 0.4 in the mild strokes didn't show the same amount of bleeding from our 2010 study, and so maybe 0.4 is okay. Yeah. It's not as bad as we thought.
Yeah. So again, we go from there, but now we're getting close to like 2018.
Yep. So 2018, now the Extend IA-TNK comes out with part 1 and part 2, very well done studies. And so these are CTA confirmed LVOs, right? And they're using the low dose or 0.25 mg per kg of Tenecteplase versus standard Alteplase. And they're going for the primary outcome is either reperfusion or absence of a retrievable thrombus when that patient goes up to the neuro IR.
Okay, that's a new one.
Right, so it's not this surrogate of like neuro improvement at 24 hours. They are actually going, is there a clot we can get in a matter of an hour or two, right? And then they look at some of the more patient-centered outcomes for the secondaries, such as the 90-day MRS and everything else that standard stroke studies look at. So what they find is kind of what we were expecting. Tenecteplase works better at getting reperfusion of LVOs compared to Alteplase. It's more fibrin specific, it's a little bit more potent, and so they're finding about 22% of the time, by the time the patient goes up to the neuro IR, there's not a thrombus to pull out. Perfect. Versus Alteplase only happened about 10% of the time. And so not perfect, but significantly better than Alteplase. Part 2 does a similar thing, but they try to compare 0.4 mg per kg of Tenecteplase versus 0.25. Okay. See, hey, maybe if you give a little bit more, you get a little bit more benefit, and they found no difference. Okay. They get 19% reperfusion regardless of the dose, and not really a significant risk of bleeding.
Perfect. So
either.
Now we sound okay. We're still going back and forth between that 0.4 to 0.25, and it may not make a difference.
They didn't find the bleeding risk with the 0.4.
Yeah. So now we kind of take a look at everything we have. The earlier studies probably didn't find too much. The later studies, again, seem to find more and more, and that becomes interesting.
And again, it depends on what you're looking for, right? And so if the early studies are looking at these patient-centered outcomes of like your modified ranking scale at 90 days and like the big picture things, but one, they might not be powered to meet that, and then some of the newer studies are actually looking at the thrombus, and because we can use that surrogate of thrombus reperfusion and outcomes, and they're finding it gets better reperfusion. Okay. So it might work.
So that's something that makes it intriguing when we look at all this stuff and say, overall, again, it's no worse for the mild ones, right? And when we start looking at these patients, and particularly LVOs, I think it's been a big push here, and where we should be looking at. Yeah. It may be a little better, and the dose may not matter.
Yeah, and so where we're at is kind of like 0.25 mg per kg is going to be better than Alteplase at reperfusion of an LVO, but likely not as good as going into the neuro suite and actually getting a stent retriever. Yeah.
So I think the big thing is like focusing more on just how can we use this in a lower dose that we can, and then using all of the technology that we have to make this happen. So. Seems pretty legit. Now, what are the guidelines saying about all this? Because that's what everyone's going to talk about.
Oh yeah, we have to default back to the guidelines, right? And so the most recent guideline update in 2019 is saying that it's reasonable to do Tenecteplase at 0.25 mg per kg in people who are eligible for a thrombectomy. So these are only in LVOs. Can you do the 0.25? They then give a recommendation that says 0.4 mg per kg is okay for people not eligible. So these small vessel occlusions, they are actually recommending 0.4 if you don't have Alteplase to offer.
Okay. So you have based off what you got it's more of a combination therapy. You go into the neuro suite, we can drop the dose. Yep. If we're not, can't do much. You may give the 0.4 and it may be all right.
Yes.
Okay. That seems legit. All right. So again, we talked about future studies. Again, most of this is based off like a couple months. Again, things have changed a little bit over the last week.
Oh yeah.
So we may have a lot more answers to some of these questions. Is there, like, again, excluding the one that just released recently, what else is coming out to kind of help us understand this question of Tenecteplase and stroke?
So there's a lot of unknowns about, like, just like they've done with Alteplase, can we stretch the window out with Tenecteplase? And so that's going to come out. We're going to look at a primary outcome in a test 2 of your MRS. So again, the legit patient-centered outcome of 0.25 mg per kg of Tenecteplase versus Alteplase in small vessel occlusions. Nor test 2, part 1 part A just came out. That was a fun one. I can't wait for part B. And then we were looking at one that really strikes home is mechanical thrombectomy plus drug or Tenecteplase versus mechanical thrombectomy alone.
Yeah.
What happens?
And I think we have to kind of caveat this for a second because, like, mechanical thrombectomy, I think we're using this one word like it's been the same the entire time. It's not one intervention to me.
Yep.
From what I understand, when I talk to my neuro guys, like, what technology do you have now that you didn't have in 2015? And they say, oh, it's completely different.
Oh, they've evolved with the various brands of their stent retrievers, their process. Are they providing intra-arterial therapy? There's a lot more to be discovered with that surgical process.
So I think we have to kind of caveat all this by saying mechanical thrombectomy, again, going to the neuro suite, you're not getting the same level of care that we did 6-7 years ago. So it's really changing, I think, for the people who's making these products. Somebody's making a lot of money. It's not me, but somebody's making a lot of money by doing all of this. So I think it's intriguing. But let's talk about medication safety because, again, when you want to make a protocol change, talk about some of the things we have to consider.
So by definition, TPA encompasses both Tenecteplase and Alteplase by definition. They are both tissue plasminogen activators. And so ISMP is actually not recommending to use the abbreviations TNK or TPA at all. You want to use either the full brand or the full generics for either of them. And because there are various indications for all of them, right? It's not just for the brain. Some places don't have cath labs, and we're using it for STEMIs. But again, there's PE, there's frostbite, there's you name it. These lytics are being used, and so maybe we should state the indication on the order so you know which one they're using. And there's also the possible concern about carrying 2 fibrinolytics in house. And so, which one do you reach for on the shelf? Is that what the physician actually wants? Or is that by accident, right?
And I think a lot of this, it becomes unsafe when you talk about verbal orders that we're having in the ED. And I say, I want TPA.
Yep.
And I think about the times when it's 2 in the morning and I'm not there. Some shops have pharmacy overnight, but what happens when you get a patient that's getting transferred and they say they got TPA? They say, oh, I got 50 milligrams of TPA, and I have a patient. I'm like, wait a second. Did they actually, they gave 50 milligrams of IV push. This is horrible. So you start wasting resources looking for all this stuff, but it's really they received the right dose of a different medication.
They got TPA,
and it just wasn't the actual terminology that you were used to. So I think a lot of this, again, I've had things happen bad for simpler things. So I think it's intriguing that we mentioned that when it was trying to make a protocol, and anyone who's been to committee, whether it's been our safety committee, PNT committee, it's always that one person that just like tries down this pathway. So you better have this on point and figuring out where you're going to do certain indications, certain drug, or just completely switch them over and make sure that all your
it's got to be foolproof so that when you are not there, your cell phone's off, everything flows.
Yeah, I like to think of it this way, and I'm going to offend someone, but it's fine. I like to make everything to where the dumbest person in that profession can't mess it up. Like your worst pharmacist, your worst provider, your worst nurse, your worst everyone. Like they just don't care. The most reckless person can't mess it up, and that's what I make my protocols for.
That'd be the safest process. Yeah.
So we have that, and then we mentioned the safety, the operational. Good God.
There's a bit to consider. So something we haven't even discussed yet is Tenecteplase is not FDA approved for ischemic stroke. Alteplase is. And so with that being said, the manufacturer is the same. It is Genentech for both Alteplase and Tenecteplase. Genentech has a fantastic spoilage replacement for Alteplase for ischemic stroke, so that if you mix the drug and then, right before patient's like, I don't want it, or I now can move, you could actually return the drug to the company and they give you a vial replacement. There's no money lost. If you're using Tenecteplase for ischemic stroke, it doesn't work.
Yeah.
Just because it's not FDA approved. And so if you mix it and don't administer it, you eat that cost.
And that's the tough part, because I've probably, this year, probably 8-10 valves. But it's based on the fact that it's like, oh, don't worry, we can just return it.
Yep.
And if it's a switch over and your team's not completely with that, and
Yep.
they're just used to that same practice, just mix it. And if you guys have not been part of a process where you have someone sitting there like nervous as crap about giving TPA, it's up.
Time is brain, right?
It is bad. So I think that's one thing to consider as well.
Well, so what if you got rid of the consent piece?
Yeah.
And so now the patient can't, at the last minute, say, oh, never mind, I don't want it, even after you already mixed it. And so now, I mean, this is a big legal, ethical conundrum, but if you're no longer consenting the patient and you just push it and give it, maybe you have less spoilage.
Yeah, it's definitely a challenge. Acquisition costs.
Like we said, a little bit cheaper, about 25% cheaper for the Tenecteplase. Hey, that makes sense. Depends on your volume.
I would say, the audience is one who actually does this.
Start talking about drug costs.
Perk my ears, and all my Atmans listening, let me know if it's true or false.
Yeah.
And then we start talking about this drip and ship. This is something that I think actually happens quite a bit for me.
Yeah. With the drip and ship, I mean, not all these patients present to a comprehensive stroke center, right? I'm fortunate where I am, where we can quickly assess these patients, get the Viz AI, and see that they're having an ischemic infarct, and we can send them up to the neuro suite. But the majority of the country goes to primary or stroke-ready hospitals where they are lytic trained.
Yeah.
And so maybe the best process is to give them a quick push of something so that in their transport, whether we're going helicopter or by ground, we're not having to worry about the IV bag or the bottle of TPA rather, and do we have to change out the bottle to the bag and flush the line kind of deal? And it might be a little bit of coordination. So maybe a 5-second push of a lytic is better.
And then it's like access. That's one thing I think about as well. Like, I had a patient decompensate en route, and I ended up like getting with my provider, like, hey, I only have one IV working right now. He's a hard stick. I have TPA running.
Yep.
Do I stop this? Like, your pressure's like 60s over 40s. Yes, stop it. But that brings up a problem where everyone's not going to think of that situation
Exactly.
the same way. So I even think about just from the logistics of just, you now have a free IV in case things hit the fan. I'm always thinking, what's the worst thing that can happen?
Yep.
And I like type a line, and they're like, no. Like, your neuro, do not stop the TPA.
But again, if you push it, you can't take it back.
Exactly.
It's in you.
So it's a little bit of both. So
You're committed to it.
you have that, and I think just trying to figure out different things. Talk about kits. I think you guys had some of those before.
Yeah.
I don't know if many other people have kits for their TPA, but it's something that we have to consider. And then which product do you use in each kit?
Exactly. So as long as you have if you're using stroke kits, you have to be able to differentiate them for like your STEMI kit, for instance, right? Pretty much the whole country, if you're going to use a lytic, is gone to a Tenecteplase driven STEMI kit. But are you going to have a different kit for strokes?
Yeah.
And so as long as everything is appropriately labeled, is a really big ISMP safety thing.
Yeah, that's really something I have to consider as well. So we kind of talk about some of the spoilage, and then like diving deeper into some of these like pharmacoeconomics that is looking at this.
Yeah, so a economic analysis of the Extend IA TNK study, they found a huge cost savings when you're looking at the country. And so not necessarily on the patient-specific level, they didn't find a cost difference on the patient, but when we were looking at an estimation in the country, like the ischemic stroke burden in the United States, they found that if you switched every patient who had an LVO over to Tenecteplase from Alteplase, you could save over $350 million a year. And that's because we're avoiding neuro-IR and we're having some better reperfusions. And so it might make sense on a big picture scale.
Yeah, it's like all the admins out there, that's listening. If that's something that you're intrigued with, that may be the way we push this on the C-suite level. I don't wear suits and stuff, so all our C-suite people that's listening, you guys take a look at that. All right, so looking at at all of this, again, we talk about a lot. The data may be there to do so, and maybe
and if it's not, it's coming.
Yeah. Oh yeah, we have a lineup of studies coming. Yep. Now it's okay. What's the big takeaways from all of this?
So if the patient's having an LVO and they present to a comprehensive stroke center, we might be going towards the way of STEMI management and say, let's not mess around with the ED. Let's go right up to neuroangio and let's get that clot out. Again, not every place is fortunate enough like that to have 24/7 neurointerventionists. And so what if you show up to a primary and you have an LVO? The drip and ship might be the best method, right? Because now we're getting the best chance of reperfusion, has a little bit cheaper, and it could be safer for an operational issue. And then for the other side, actually the majority of ischemic strokes are going to be that small vessel occlusion. I don't know what lytic strategy might work. Yeah. Honestly, there's been studies for Alteplase versus aspirin. There's going to be a Tenecteplase versus aspirin study coming out, and I'm not convinced.
Oh, I'm not. You know I'm not. But it's just something we have to consider looking at all of this. So it's intriguing to say. I think that's a decent amount of data and that talk about most of this. But it's just intriguing to think that this is a question that a lot of places are having to discuss now. Like from a cost standpoint, is it a deal? From an efficacy standpoint, and I think the real question becomes in. I think we kind of overgeneralize all of our therapies across the board, and it needs to figure out how can we get deeper to like which patient requires which intervention. Because I always say it's a right drug for the right patient.
Absolutely.
And there's a wrong drug for a lot of patients.
I consider medications like this that are tools, right? And there's a right time and a place to use a certain tool. Yeah. And there's other times when you should not consider that tool. You know, when you're a hammer, everything's a nail.
There's a lot of hammering going on when it comes to ischemic stroke, but I think that's really the big thing. I think thank you for coming, and this is something that's special. I think the first of its kind. And anytime I do something the first of the kind, I have to get the best of the kind to come with me to talk about something that is just unique. And stroke care, is very special and near and dear to my heart and brain. No pun intended. But it's definitely an interesting component. And yeah, I think overall we should something we should look at. If anyone's listening or watching, comment on this, what you guys are using. What's the therapies that you think makes the most sense? But I think anyone who's like touting that they know exactly what we should use right now, I'm gonna look at you a little sideways because I don't think you know what you're talking about. So we have some stuff that says we could be leaning one way, but I don't think it's a slam dunk yet. But we have done drastic changes with even less data, so it's intriguing to say. But I'm gonna wrap it up there. And again, all of you guys watching, this is gonna be the first part of our Pharm So Hard tour. This is something that is just unique to me, and I'm unaware of anyone else who's been doing a podcast tour and talking about pharmacy-related material.
Making it fun.
Yeah, please let me know if you are doing it. We're sitting there having a good time, drinking some beers. Again, all this information is going to be on the website at pharmsohard.com. And then one thing to look out for, not just this, but we also have our major platform, Pharmacy and Acute Care University. Again, all that stuff's going to be on the website. I don't want to talk too much about that. But again, I'm going to close it out the same way I do every single episode. You don't have to work in the ED. You don't have to be a pharmacist. Everything you do, make sure you Pharm So Hard. Thank you.
Thanks for having me.